Hi everyone, my name is Phoebe and I'm here with another video. This video will be specifically focusing on how to create study guides for PA school. I do have two other videos. One of them is a general overview talking about all of my study tips and tricks of how I did very well in PA school, both didactic and clinical years. If you want to check that out, link will be below. And my other video is going to be on how to use the study guides that I made specifically, also link below. But in this particular one, I'm going to be going over how I made them, the process from beginning to end, so you can use this in your studying. Just to provide a little bit of background, I recently graduated PA school. I will be starting work in just a few short months. I graduated summa cum laude. I was awarded the National PA Student of the Year Award, which was really, really awesome. So I'm sharing with you exactly how I created my study guides. This is basically what I attribute a good portion of my success in PA school to. I've been studying this way ever since end of high school, all the way throughout college, all the way throughout PA school. I know normally people tell you kind of need like the first semester of PA school to really figure out how you study because it's going to be different than what you did during college or before. But for me, this was honestly perfect. It worked out really well. I didn't spend a whole lot of time trying to figure out the best technique because this really came in handy and worked out well. Again, separate video on that, but this one will just be on the study guides. What I'm going to do is first talk about the benefit of using the study guides, kind of why I did them, and then later on I'll go into a complete tutorial kind of showing you how I would actually make them. So I'll be sharing my screen and then you can kind of follow along, and then at the very end I'll just give a little kind of tidy everything up, talk about my specific study guides, which I do have them if you for whatever reason don't want to make your own. I mean, I do have all of mine as well that are up on my website, but if you're here to make your own, this is exactly how you're going to do it. I'm going to talk about some of the benefits of making study guides and studying this particular way. There are many different ways to go about PA school, but I just feel like out of every method that I've seen, and you definitely see a lot, what you're doing, what your classmates are doing, what you've heard the year above doing, this is the one that I absolutely swear by. There is kind of the saying how you need 3 passes of any new material to kind of have a good handle on it and be able to do well on an exam. My study guide methods is basically I will look at material ahead of lecture, so before we even talk about it ever in class, because the lecture material is probably already out. I will make the study guide then, and that first round of reading the material and converting it into a study guide format is my first pass. And then the second pass would be during actual class time when the professor talks about it for the first time. That's your lecture, that's your entire second pass. The last third pass is when you're actually going back and studying. So this way you're not kind of cramming all your 3 passes from when lecture starts and after. This way you're kind of just splitting it before, during, and after lecture. When you study this way, it actually helps you learn it a little bit better, actually a lot better, and helps the information stick. Basically, by doing things early, you're utilizing your class time and your later studying time better because you're not going in completely blind. When you structure your studying this way, you tend to remember information better because you're learning about it in 3 different environments. And that's kind of like you don't really think about it, but when you do study the same material, but in different environments, you kind of have a better way of memorizing it versus if you just studied all of it at home. You're probably sitting at the same table or your couch and just reading it over and over. And that's the only way you're studying. It actually isn't as effective as seeing the same information, but you're kind of in 3 different environments. It just sticks better. And then another benefit of doing the study guide method is that you have everything all in one spot. So this will be your main reference material whenever you need this information. By having a very comprehensive study guide, putting in the work up front, looking at things early, creating this document that you can refer to at any time is absolutely key. You will not be using the slides, the videos, the podcasts, whatever you use, and like referencing all these sources that are just kind of like scattered and you kind of have to remember like where you found information. There's none of that. Everything should just be in this one document and that's what you're referencing. So it's very convenient for when you are getting towards crunch time for studying for exams. Also, even after that initial exam has passed, when you're going back and reviewing for, let's say, clinical year, it's very easy to just be like, I need to know this information on this topic, and it's right there. You're not trying to pull from a million different sources again for like the 10th time. So it saves you a lot of time, and it's also better for memorizing. Once you look at this document so many times, you can kind of remember more or less the positioning of everything on the document. Let's say I have to review gout again. You've probably looked at your rheumatology study guide at this point, like the same one, so many times that when you look at it again, it'll be like, oh, like I remember this, I remember that, I remember this. You probably even remember it's on like this certain like section of the page and it's only this much and it's quick. Versus if you're learning about the same topic, but it's like, oh, I'm using this resource one day and then I kind of forgot it. And then I'll use a video to like remind myself the next time, but I kind of forgot it again. It's just like all these different formats. You don't have this one thing that your brain is constantly thinking of in terms of, I know this information is correct. I've seen it a million times. I remember it better because it's in the exact same format. It's just a lot easier. I also did want to mention lecture slides. The majority of your classes will have lecture slides. These are the slides that you should be kind of pulling your main information from, especially for didactic here, because it's your professors that are going to be writing the exam. There aren't any PAEA standardized exams to take during that first year, so it's probably your professor that's coming up with the questions. And where are they coming up with the questions from? What they taught, which is their slides, the class, the lecture, so their stuff. I would say for that reason, slides are a huge thing. A lot of these slide decks tend to be tens, often hundreds of slides long. You should be looking through all of them once and then consolidating it into this one study guide document. Then you won't have to look at them again. You won't have to look through this many tens or hundreds of slides. So you're saving yourself a lot of time later on studying as well, because you've already cut out less important stuff. For whatever reason, you determined it wasn't important enough to make it into your study guide. So you're not re-wasting time looking at the same things and being like, I know that's not that important to know. If you just made the study guide and then left the slides after that, you wouldn't be wasting brain space and effort and time doing all that all over again for no reason. On lecture slides specifically, I think you have to think about it two ways. I would say this is the minority. Some professors do like the proper thing to do for lecture slides, which is to have bullet points and not just cram as much information as possible on the slides, because for proper presentations, you're supposed to use like big font and not have too much and just know your material more and be able to talk. So that's kind of one end of the spectrum. In that event, there's probably a lot of information missing. So that shouldn't be your final review information. And then on the flip side, I think this tends to happen more frequently, is professors will kind of go the opposite route, have like tons of tiny, tiny little words, full sentences, every picture that they found like while they were creating the PowerPoints. And that's like the slide sets that end up being like hundreds of pages long. You don't want to be using that as your final study material either, because there's just way too much on there. And it's created for that particular professor to present to you, not necessarily for you to study off of. I know for me, there's like fonts that aren't matching. If a word is too light, there's just so many extra things added, like diagrams and just a lot of like side information, which kind of helps you understand certain concepts better, but you don't really need to be like reviewing that multiple times in the long run. This is why I tell everyone, like, I can't study off of slides. If it's not formatted exactly how I like it, I just won't remember it and I don't want to look at it. So whichever side of the spectrum the slides you get fall under, it's usually not what you want to be going back to refer to when you're actually reviewing to study for the exam. Again, for that reason, I think you should be making your own study guide, because this is your personalized, accurate document that has more information than like the few bullet points, but has less information than the one where it's just like throwing everything possible at you. What I'm trying to say is that your study guide should be basically the happy medium between these two extremes. It should be the most personalized thing for your studying that would help you get the highest grade and save the most time. Something else that you want to keep in mind while you make these study guides is think of it from an exam perspective, an importance or like need to know perspective. What I mean by that is think of what will actually show up on your exam, not just like all of the information that's laid out in front of you. You need to tailor it for what's being asked. So the normal things that are being asked are symptoms, diagnosis, treatments, comorbidities, risk factors, things like that. You get a better idea as you continue studying. There's just like a certain number of categories of topics that are always asked about every condition. You'll just kind of know what to cut out to keep it short, but what not to cut out so it's still complete. I think during didactic year, especially when you're first learning all the different conditions, and especially when there's conditions that are like very similar to each other, but there's certain key differences that they always want you to know, and that's how you distinguish between the two or three, however many. For those, you kind of want to think bigger picture and be like, these 2-3 conditions will probably all be options in a multiple choice because all the questions are multiple choice. So what are the differentiating factors? And to do that, you need to put them side by side or next to each other, or just format it in a way where you can easily compare and contrast. Let's just say it was medial epicondylitis, a few slides on it, and then you'll go to lateral epicondylitis, and then there'll be a few slides on it, but there's no like real comparison. If you just stuck with the slides, let's say you didn't make your own thing, or like maybe you scribbled in the margin, you'd have to keep scrolling back and forth. It's very inefficient. Or you're just like forever trying to zoom in on your tablet and being like, what was that little note that I wrote compared to this condition? I would say group similar topics together that you know will show, like MMR, rubiola, mumps, and rubella will always be options in a question. So you really want to get those 3 clear. In all my study guides where those are mentioned, like those topics will be put right next to each other so you can like clearly see the distinctions between the 3. And then lastly, I wanted to mention, when you do have a very comprehensive singular document like this, you make it during didactic year. For clinical year, those study guides are for the EORs. So you can just pull information from whatever topic you need from the ones you've already made. So you're not like remaking that or like having to look at the slides again and like remake information. You're just literally pulling pieces from what you've already made into the new one. So it's for that exam. But that way, when you have these like very specific, well-organized resource, like singular resource to look at when it comes to studying, you're set. Like you're set for didactic year, you're set for clinical year. There's nothing new you have to make. If you have like that callback period, like a lot of PA programs after you finish your first 2 years, there's like 2 or 3 months after that, where it's kind of just your capstone, wrapping up, PANCE prep, that sort of thing. So you can just study off of the exact same things you were using before. It's a much more effective way of reviewing material because you've been looking at these for so long, so many times, written the exact same way, like you know it. You'll be able to even like mentally pull it up during an exam because you've seen it in that format, written that way so many times. So you're set for that. You're set for PANCE review. If you really want to think far into the future, like that sets you up well for when you have to get recertified for the PANRE. I know sometimes you're like, oh, I don't want to like make it, but you're truly saving yourself so much time later on because whatever you're not making to a study guide now, it's just gonna stay where it's at, whatever slide set, video that it's in. And every single time you have to go reference back, you're gonna have to go try to find every single one of those again. And that just eats up so much of your time. I swear a lot of people are like, I thought you studied all the time and I was ahead of everything. But like I truly, if I knew I was spending extra time on something that I could have done earlier that I didn't need to be spending time on, but I did later, that would annoy me so much because I was like, I could literally be doing anything else right now, productive or not. I definitely got used to this, saved me a lot of time, opened up a lot of free time to do other things, and I'm gonna share it with you. Okay, so now into the tutorial portion of this. This is usually what I had in class, half slides, half the study guide that I was working on. If I was at home or anywhere else, I would just have my entire screen be the study guide, so like this, and then the slides I would put up on my iPad on the side and kind of read that way, so I had more space to look at it. But for the purposes of this tutorial, I'm just going to do it this way. I have pulled up a slide set. This is the esophagus when we were learning GI, so all of the esophagus related conditions and disorders. As you can see, this one is 34 slides long. Obviously there's esophagus, stomach, small bowel, large bowel, like all of it. So there were 11 slide decks in total. I would say on average, they were around 25 slides long each. So that, I believe, is 275 slides. And that's kind of a ridiculous amount, personally, to keep looking at over and over. So I'm going to condense that down. Obviously, this is only one tiny section of GI, but I think my final GI one ended up being around 12 pages. But let's get into it. So I did all of mine in Google Drive just because it was easier for sharing, but feel free to use whichever one is better for you. I mean, the whole thing would end up being the GI study guide, so I'm just gonna write GI study guide because everything else would be going in here unless you wanted to make just one for the esophagus, one for the stomach. But I think having one entire module's, like all of that information on one study guide is very helpful instead of trying to flip through, again, more documents. In terms of formatting, you can definitely do this however you like to. This is how I would. So first, Calibri is my favorite font. I feel like it's the most compact and non-fussy and still like visually clean looking. So GI study guide, and then I liked adding page numbers because I would see how many total pages there were, and then I would chop it up in 4 pages approximately, because that's how much I knew I could sit and actually study in one session. So let's say, again, it was 12-page study guide. I know I can finish 4 pages in one sitting. That would be 3 different sittings to completely finish studying the study guide. So that was useful for later when I had to figure out my schedule on when I was actually gonna look at the study guide and what day things were gonna get done. I'm going to actually, let me zoom back out. This is why I like having it on my iPad, but this will have to do for now. Let me see. Usually I would do 3. So we'll just start that way. Everything's a table, everything's a square, 1 condition per square is how I like to do it, just so each square you can just take a look at and be like, oh, this is a very complete picture of this condition. I'm just gonna go step by step. This kind of has an overview of everything that is going to be covered in the slide deck, which is helpful. What I would do is go through all the different topics to see how I would need to arrange it first, kind of like what needs to be grouped together or split apart, because sometimes professors will just go through conditions with no rhyme or reason, and it's very irritating when you have to go back and compare. So here, let's just say, again, I don't like this font. I also used the dreaded single space, but it helps everything stay on one page easier. And it's good for just like visually compacting and like seeing things together. So esophagitis, GERD is definitely related. So I'll put it with esophagitis. And then I kind of obviously have an idea of what each of these things are already because I finished PA school. But if you didn't know, you could also kind of just make 3 boxes like that and just fill them in with conditions. And then later, once you're kind of going through and figuring out what each one actually is, you can kind of rearrange the formatting and which ones you put next to each other. Since I know what these are, I'm just gonna kind of leave them. Esophagitis and GERD definitely go together. Mallory-Weiss-Taran-Boroff syndrome are more similar than they are. I'm gonna delete this column and then make a new one and put these 2 together. Motility disorders kind of seems like it's on its own. Sometimes there will just be one on its own and it's fine. And then I'll just make a note. This, let's say, because if I looked at this for the first time, I wouldn't know what achalasia necessarily was. So I just write that down, motility disorder. And that way I'm making a note of it wherever this ends up going. So I'm not worried like, oh, I forgot something about achalasia that was in the first slide and now I'm 15 slides down and I can't remember like what I wanted to add. Like once you're done with the slide. You never have to look at it again. That's the idea. So I'm going to put motility disorder first in this box just so I know. And then here, strictures. The next is strictures and rings and webs. Then under here, Schatzki's ring, which is a type of ring. So I'm just going to leave that under that section. These are kind of all independent conditions. Like you don't necessarily have to group them with any of the others, but I kind of like utilizing space well. Achalasia was kind of on its own, so I'm just going to put all 3 of these that are just like other esophageal conditions together. And then esophageal cancer. I feel like most professors tend to put all the cancers at the end of whatever section they're part of, and then over time I just, whenever there was a cancer, even if it was mentioned earlier, I would just automatically move it to the end, so I know like cancer is what's being ended on. And I feel like maybe it's because we all know they're like very significant diseases that they're just kind of easier to memorize, like the signs and symptoms for. They just stick with us a little bit better, so I feel like it's not as important like from a memorization perspective to have them necessarily like first thing within that section, because you'll probably remember it anyway, versus like, let's say like you can't remember what achalasia means. Like this might be something that's better to put like a little bit earlier for review purposes. So basically this is a rough outline of everything that's going to be covered, so you can kind of see what you have to fill in and what there is left to do. I just put in the title. Each section obviously will be whatever the condition is. So the next one, for instance, would be stomach. So once I got to that slide set, I would repeat this process. I like the actual content to be size 8 font, and then the titles to be a little bit larger, so the titles stick out a bit more. I think that's more helpful for studying. I know it's like very tiny little details, but I've definitely kind of created a system where I'm trying to cut down as much on like wasted energy as possible, and one of the easiest ways to do that is to make the important stuff stick out to you first. This is the entire esophagus section. Looking at this next slide, the esophagus propels contents. I'm sure you already knew that. You don't need to know it's 8 inches long. I would be very surprised if that ever showed up on an exam, and even then I would just say use your best judgment, but I don't think that will ever show up. And then it just explains what peristalsis is. If for whatever reason you didn't know what the definition was, maybe include that, but I would say you kind of use this word enough to be able to know what it is. So I would say you don't need to include any of this information on the study guide. This side, obviously the picture. Again, I don't think they'll ever create like an anatomy diagram like this and necessarily be like, what is this? What is this? It'll just ask you sometimes to interpret like an x-ray or what's happening or what condition this is, but it won't be like name the anatomy. So we're gonna skip that. Okay, so first condition, esophagitis. Again, pictures on the side. If you just look at this from a slides versus study guide perspective, this is kind of wasted space. Like you don't have to keep looking at this. I'm sure you have an idea what an esophagus looks like. And then let's go into here. So esophagitis refers to inflammation of the esophagus. Itis is one of those first things you learn, is just inflammation. So I would not include that unless you just really wanted to add a definition. Normally what each condition covers are more or less like the same 7-ish topics, and sometimes there's certain ones that aren't relevant and you can just delete those, but it's usually like causes, symptoms, diagnosis, treatment. Sometimes it'll be like prognosis, which I'll add at the bottom. Sometimes there's like risk factors, demographics, sometimes pathophysiology. You can literally just like do this and like copy and paste this into like every single one and then just fill it in. Like you could have this preset and just fill it in for every time you get a new slide deck. We'll just go in order and fill it in. Occurs secondary to, so this will go under causes, so reflux. And then most common, I would usually put most. You could also put like MC. I don't know why, I just always kept most. Infection here, more often in immunocompromised. I feel like depending on where you are during PA school, like you may or may not include stuff like this, just because if you're immunocompromised, you're more likely to get infections. So I would honestly say skip this, but if you just prefer to have it in, you can definitely keep that in, but I'm gonna skip in mine. Certain medications. This one actually did come up on quite a few questions in second year, so I am gonna include it. So I'll just do meds and then list these ones. So tetracyclines, NSAIDs, bisphosphonates. This is the reason why. When you actually read it, it's just all they cause inflammation basically. So I'm gonna skip this whole section. Autoimmune. And then depending on how you like to do it, sometimes I'll like look at how much space everything is taking up on the page. Sometimes I'll have it this way. Other times I'll literally bullet it out like this, like have all of them out of bullets. It really just depends on your personal preference or how you want the page to look, because this takes up kind of like less space lengthwise. Reflux being the most common, I usually bold this and I usually highlight just so I know. So your eye is kind of like drawn to that when you're studying, and then all these other ones are kind of less important. Autoimmune. This one go here. This one I am going to include just because this one has come up a few times, not commonly, but I think it's important to know. So I'll put types here like eosinophilic. And then diagnosis, I'm not gonna write this whole thing out. Everyone just says EGD, so that's what I'm gonna do. And then you can write just so you know what it is, because later when you're studying, you don't want to be like, what is that again? And then have to look it up separately. So you can write upper endoscopy. That is the gold standard. So if something was the initial diagnostic modality versus the gold standard, I would make sure to differentiate that. Highlight the gold standard. Well, I'd highlight both because they ask initial versus gold standard quite frequently, especially for like strep throat, for instance. So you can use barium swallow. I'll just do like plus or minus barium swallow. Again, not including that. Moving on. Like, why is there an entire blank? Yeah, I don't like slides in case you haven't noticed. Okay, so presentation symptoms. Oginophagia, which means painful swallowing. You either write the word, you can write down what it means, you can write down both. I think these are easy enough, so I'm just gonna write the medical word, heartburn, and then like it'll come as you do more practice problems. Retrosternal is a term that's used a lot for certain conditions because a lot of times the only way to describe it on a test question is to describe it using certain words, and retrosternal is used a lot, so I'm just gonna put in parentheses that specific word so I know. It may not be responsive to typical GERD treatment. And then treatment, treat the underlying cause. I would honestly leave it at that. I know you can write down infectious if it's bacterial, treat it with antibiotics. If it's medication, you stop the medication. Just use your best judgment. I don't think that's something you have to like keep studying over and over necessarily and like put it in your study guide and list it out like this. If you think it'll help, by all means, include it. I'm just going to not, because I know if any of these came up, I would know what the thing to do was. And then supportive care, that's fine. Here's another picture. So again, very helpful when you're like looking at it for the first time, but not necessarily to have in your lecture material. More pictures. So again, we've barely even started, and this is all the information that we've had to write down so far, and we've already covered like 5 slides so far, 6 slides. Okay, so GERD. Something else that I do when there are abbreviations, I usually write them out. So just look it up. It means this. I'm just gonna type it out. Yeah, I put these two together because they are related. Oh, again, these didn't show up, so I'm going to delete these. I'm going to get into the GERD slide. Some reflux of the stomach contents is physiological, like that's all whatever. Refers to reflux that causes troublesome symptoms and or complications. Like that's all kind of throwaway language. Causes. So here we are. Causes. Gastroesophageal junction. Incompetence. This I just know because I've looked at it so many times. It's abbreviated that way. And then I also have lower. So for long ones like this, because they already take up almost the entire line, I just bullet them out. Okay, let's say you didn't know what either of these meant. I think it's very important to be making sure you understand everything on all of the slides as you're reading them. So that way, 1, you actually know the information. 2, there's not like a thought later, oh, did I miss something? You kind of know everything's accounted for. What I would recommend is open evidence specifically for these types of questions, because this is all pulling from peer-reviewed journals, evidence-based. So I would literally just type in like, what is this? And then as it was kind of moving it along, I could go back and work on it and then come back and look later. This refers to the failure of the anti-reflux barrier at the junction, causing abnormal reflux of gastric contents into the esophagus. So let's say you didn't know what it meant and you're not sure you would know what this meant later on. Feel free to just write in a quick definition here if you needed to, like that's totally fine. I'm just gonna leave it. Characteristics of refluxate. So page 2, I'm assuming you would kind of know this because like a stomach acid is very acidic, so what's coming up is probably very acidic. That would probably be something to put under here. You can just write acidic, increased pepsin. Let's say like you didn't know what pepsin was, you could also just, like for simple things, yeah, so it's a stomach enzyme. And you can also write like stomach enzyme, which makes sense because it's stomach contents going up. Impaired esophageal acid clearance and emptying, diminished salivary function, impaired defense, esophageal hypersensitive. So this is kind of all describing the same thing. I'm not going to include it. Again, if you feel like you need any of that information, feel free to. When it comes to like these types of things, sometimes you'll realize, especially when you have all the things written out, there are things that are missing. So it's also easy to see what you need to supplement if you do need to supplement. So I'm just going to take this out. For symptoms, diagnosis, treatment, This particular condition just so happens to be the same as this. So I'm just gonna write same. This way you can kind of tell. And let's say it didn't give you how to diagnose something, or it was only said in class, but it wasn't in the slides. You'll know to go look for it on your own later. This was not mentioned, I believe, in the beginning when they were going over all the topics. This is what happens. We're gonna go to the right because this is kind of related to these two. Again, copy and paste. Herniation of elements of the abdominal cavity through the esophageal hiatus of the diaphragm. So it's basically your abdomen herniating up. Abdomen into esophagus. Do it like that. Okay, so this is a types thing. 95% are type 1. So I would say type 1, and I would put most. I don't think the specific percentage is that important, so I'm just gonna write most. Because also just knowing that something is the most common is usually what you need to. I think if you actually put a number down, whether you realize it or not, you're committing energy to like memorizing that specific number, which you don't need to be doing. So this is sliding. And then here's where I would say you kind of get an idea of knowing what you need to supplement based on what is missing. So this said most of them are type 1s. The fact that there is a type 1 implies that there is a type 2. So what I would do is I would separately type in types of hiatal hernias and then wait for that to come up, just so I would know the others, because I think having like a complete list is important. Type 2 and type 3 were, I didn't even know there was type 4 actually. So type 2, again, highlight the most common. So that's why we highlighted type 1. Type 2, paraesophageal. What was this one? I think this was mixed. Yeah, and then type 4 doesn't even have a name. Additional, I'm just gonna say additional abdominal organs. Other, yeah. And then this is one of those instances you can add a picture. This actually might be a helpful location to actually put pictures so you can kind of see the difference. I was kind of a stickler on how much space things were taking up in my study guide, so I would tend to not. However, you definitely can. Something else that I would recommend doing if you also don't want to take up too much space in your study guide is just keep it like this. And then if you need to search up pictures while you're studying, just look it up on the side while you're actually using this. And I think that's also helpful because it kind of helps you create like a mental picture of what things look like. Let's just say you got a question talking about hiatal hernias on your exam. There's no guarantee that they're going to be giving you a picture anyway. So sometimes it's good to be able to picture what it looks like and kind of answer questions that way instead of just knowing like, oh, this was the picture. Because sometimes they'll just be using words to describe it. Anyway, let's get back to this. I'm going to look at the imaging. Same thing here. Contributes to GERD by compromising that. Add a section down here, like complications, GERD. And this is rarely surgically repaired. So let's say like type 1. Okay, you know what? Here's what I'm going to do. For each of the above, what is the most common treatment? And just let that run. Okay, so type 1 is managed medically, and then the rest are surgery. You can either put it separately here under treatment. Honestly, for this, I might actually, sometimes I'll just, if it's I already made a list out like this, I'll just put next to it what the treatment is. So that way everything's kind of in one spot versus having to look down. But I think this one's pretty easy. So I'll just do type 1, medication, all others, like surgery. Diagnosis would be the same. If you didn't know that, you could definitely look it up, and you kind of know it wasn't covered, so you know that you need to look it up. Cause, actually, we'll go here. And then diagnosis, same, symptoms, same, yeah, for GERD. So, okay, now we're back to GERD. See, these are all related, so it's good to have them next to each other for comparison. So let's say like risk factors, and we could just write all these down. Lifestyle. Okay, so we're already about a third of the way through, and That's all the space we use. So it's very efficient is what I'm trying to say. GERD, yeah, symptoms again, heartburn, regurg. We said same as here. Again, retrosternal. Oh, these are some other things. I'm gonna add, honestly, here, because these two are like, this is just the inflammation that's caused after, and then these are like reasons for it. So I might just add, and then if you didn't know what that was, obviously you can write like lump in the throat. Actually, you know what? I'm gonna take it back. It is kind of a heartburn thing, or GERD. I'll just add it on like that. Oh, okay, so my bad. Yeah, this is a clinical diagnosis first. However, you could also, if it wasn't resolving for some reason, you could do the EGD. Clinical diagnosis, yeah. There we go. And then these are red flags. Yeah, we go into it next. So I'm not gonna put in this section because this is more for Barrett's esophagus, cancer symptoms. So I'm actually going to take that out. I'm gonna move that up here because we're kind of getting into the cancer section. If something was pre-cancerous, I wouldn't put it all the way red, but if it was increased risk of cancer or associated with it or something but wasn't actually, I'd put it in orange. It's less of an alarming color but still indicates that there's something abnormal about it, like new onset GI bleeding. I just know this is the abbreviation for iron deficiency anemia, but you can write out the whole thing. Remember, these are also just found in normal esophagitis. I don't think that's a symptom. You know what? I'm actually going to take this out. I feel like this is kind of common sense. Like if you have a family history, you're more at risk. And your mind would probably go to that anyway if it showed up on a question. So I'm gonna delete that. Again, you kind of figure out what you need to include and what you don't later. I think this will be the last one because I think I've gone through this enough, and I'll go over a little bit more like formatting things. This is the important part. This is the distal esophagus. So sometimes I'll put like location and I'll underline it. Because there's another type, like the more worldwide common esophageal cancer that tends to be upper esophagus. This is specifically distal because it's because of the stomach contents, like constantly irritating that area. So it's coming from down below, like inferior. So that's why it's a distal esophagus. And this part will get tested on that. This you also have to know histology, which is like the tissue. Basically what is happening is metaplasia. If you didn't know what that meant, just Google it or look at open evidence. A certain type of cells replaced with different kinds. It doesn't explain the slides. I would definitely recommend looking into it because I'm a huge proponent of understanding the pathophysiology. Helps you remember everything, helps you understand everything, makes test questions a lot easier to tackle. Metaplasia. So what's normally the squamous cells that your esophagus is made of starts turning into columnar because of the constant irritation from the stomach acid constantly going up. So it's starting to turn into the cells that the stomach is naturally made out of. And once that change in cell type starts happening, that's when you start getting worried about risk of cancer because now your cells are undergoing changes that they shouldn't be. So Barrett's esophagus isn't necessarily considered cancer, but it is definitely increasing your risk of esophageal cancer. Squamous cells to columnar. And I would definitely highlight this. You have to know this. Oh yeah, this was, we had confirmed with the professor, this was written backwards, so it's the opposite way. It's not it's not columnar to squamous, squamous to columnar. This is why we care about this condition so much. Where's my arrow from before? Up. Risk of adenocarcinoma. And I would put this in red because that's actually cancer. I'll just put here also esophagitis, GERD symptoms, diagnosis, EGD with biopsy, and these are some risk factors. Here. Older age. I usually like to put sex first, but male, older age. Chronic GERD is the main one. Caucasian, hiatal hernia. Obesity, smoking, obviously for every single condition almost. Family history, yeah, I'm just gonna and management. So treatment. So there's kind of two tiers to this: mild, moderate, and the severe symptoms. Mild, moderate, step up therapy, which is kind of like you go from the less strong medications, and then if those don't work, like you work your way up, versus severe, you do the opposite. So step down, you kind of start at the big guns, and then if you seem like you're getting better, you slowly start to step down and use less intense medications. This I would put like lifestyle. If you needed to specifically say what those things meant, like weight loss, etc., like definitely feel free. I'm just gonna skip it because I think this is honestly more for GERD. I'm actually going to GERD. So lifestyle changes, antihistamines, antagonists. If you just automatically knew this was referring to antihistamine, you wouldn't have to write this. But if you knew that that wouldn't be an automatic connection for you on the exam, I would write down both. And then I would definitely give an example. For example, famotidine. It's the most common one. Lifestyle famotidine. I'm sure you could figure this out, but like PRNs, standing, I'm just not going to include that. I'm just going to include the next class, which is the proton pump inhibitor, which is PPI. If you didn't know what it stood for, again, you could write it out, but I feel like we use PPI a lot, so I'm just gonna not. An example, omeprazole, and then step down, you would just assume it's in the reversed order, so I'm not going to separately write that out. Again, you can take a look at the charts that are provided, but no need to like put this whole chart in. So I'm just gonna stop there. So we've gone through like that many pages, and it hasn't taken like an insane amount of time, I don't think. And you've cut it down. This is all you needed to know from that many slides. This is already one like very thorough round of studying, but you already have all this background. You're then going into lecture after you've already made this. Lecture really just solidifies it, and you might just have to look at it one more time, which is how I felt in PA school. So I wasn't looking at these things like multiple times after lecture. So that saves you a lot of time, and I feel like it sticks better. That is pretty much it in terms of like content. I do cover in my other video how to use my study guides, like color codes that I use for certain things that might not be showing up in this specific topic. Feel free to shift the boxes however you want, group things where they make sense, and you can have this row as it is. But let's say something else showed up later that's more related to these conditions than it is to wherever was shoved into the slides. You can just make another column or like box here and just add it on to where it makes sense. I love my boxes just because you kind of get an entire picture of like everything you need to know for that condition, like right in that one box. This is more or less the format that you'll be looking at when you look at this topic every single time you do have to reference it in the future. Looking at this particular order so many times, because of it being in the same format, you can kind of pull it up in your mind more easily later. It sticks better. You can pull it up mentally during exams better. I like to say most PA students kind of has a little bit of a photographic memory, and this kind of helps play on that. Use that to your advantage. The first few times, this definitely might feel like it takes forever, but I would just say stick with it. You'll definitely get the hang of it pretty quickly, and you'll just kind of instinctively know what to do and what information is necessary to pull out of every single slide deck and what information you should just kind of leave there. And the process will get a lot faster. When you have this whole thing listed out again, as you saw earlier, if something was like missing, you'll know that it's missing and can like look it up right away, versus you might not even be aware that, I don't know, diagnosis for this was missing or something, and a question comes up and you're like, wait, did we learn that? It's just good to be aware of that earlier on rather than later. As you're going through each slide, make sure you understand everything you're reading completely. You are already spending the time to make the study guide, so save yourself the time later and like actually understand what you're typing into your guide now. You don't want to be absentmindedly like making this, just typing everything in, but you didn't really soak up any of the information, and then you're gonna have to set aside separate time later to learn this whole thing when you could have just taken less time overall to do it while you were actually making the study guide, if that makes sense. So definitely make sure you're understanding everything that you are putting in and everything on the slides, and then just letting it die. After you made these, and let's say like the stomach comes up, you finish the entire GI unit, then certain things, if you realize after the fact, you're like, wait, this actually isn't that important to be in there, you can just delete it. or there's something that you're like, this was missing, you can go back and add it. If you were watching a video and they said something new about like hiatal hernias that you didn't already have in here, you can just easily type it in here. And it's just very easy. So like you don't even have to pull up that video again or like any of those other things. So again, I feel like this is just the most efficient way. It can be viewed as like too much work up front, but you're definitely doing way less work in the long run. So that's it. That's how it's done. Obviously, feel free to tweak it however you need to. Again, it's your document. It should be for you and how you know you study best. I did want to talk a little bit about the study guides that I made during PA school that I still honestly reference like here and there, even now that I'm graduated. I have my entire set of study guides for both didactic year and clinical year. All of the like different classes from your first year, all the clinical medicine ones like cardiology, pulmonology, ophthalmology, all of those. And then I also have all 7 of the EOR ones. So I do have mine if you don't want to make your own, or let's say you're really, really busy at a certain point in PA school and you usually make your own, you just need something to help you kind of like catch up. I do offer all of my study guides on my page on howmedworks.com, which I'll link below. I hope you found this very helpful, doing like a one-on-one deep dive, and I'll see you in my next video. Bye.